Okay, we can.
No, I will. Nana?
Can you hear me now?
Yes.
Yes.
Oh, great. I'm sorry. Some
Okay.
technical problems, I guess. So good evening, good afternoon, or good morning, wherever you're in the world. Welcome to our online conference today. Before giving the floor to our dearest guests, I would like to introduce to our team. I'll be the moderator today. My name is Nana Chanchalishvili. I'm a neurosurgery resident in West Georgia Medical Center and neuroscience master student at University of Bordeaux.
Nana, please slow down.
Online educational meetings have
cannot
started with Professor Hassan Kamil Suju, the program manager of the neurosurgical department of İzmir Atatürk Training and Research Hospital, and continues with contribution of residents and neurosurgeons who graduated to the same from the same department, and also neurosurgeons and neurosurgery residents from nearby countries like Georgia, Bulgaria, and Pakistan. I kindly ask you to keep your microphones turned off during the presentation of the lecture to avoid the voice and noise pollution. You can ask your question not by turning on the microphones, but by writing in the chat part of the Zoom program. At the end of the presentation, your questions will be asked to the lecturer and will be discussed. Mutual discussion is not appropriate for the format of our meetings. Please do not ask your microphones to be unmuted. So right now, as for our lecturers, we have two lecturers today, Dr. Andrii Netliukh and Dr. Andrii Tokarskiy. They're both from Lviv University Hospitals from Ukraine. And I would like to, at first I would like to introduce Dr. Netliukh. Dr. Netliukh is a professor at Lviv University Hospitals. So he has graduated Lviv Medical University and neurosurgical residency, as well as further training there. And he has published totally 163 publications, including the poster presentations in the local and international journals. Out of them, 48 articles in peer-reviewed journals. Dr. Netliukh, is currently affiliated to Lviv Panteleimon Emergency Hospital in Ukraine. And as for the Dr. Tokarskiy, Dr. Tokarskiy is also graduated from Lviv University Hospitals. And it is worth mentioning that he was awarded as an honorary doctor in Ukraine in 2020. And the Dr. Tokarskiy is the head of neurosurgical department of University Hospitals. And so you are welcome to start your meeting and share more details about your hospitals and your experience. Dr. Tokarskiy and Dr. Netliukh, you're welcome to start your meeting.
Thank you very much, Nana, from both of us for your introduction. Thank you for the possibility to have the speech on this widespread platform. And I will ask, and I will translate Dr. Tokarskiy with his part of introduction of speech about our hospital, about our abilities. And Andrii Yurievich Tokarskiy, please.
Andrii Tokarskiy, hello. I'm sorry, I'm speaking from Ukraine language. Я дуже дякую такому високому товариству за можливість виступити перед міжнародною спільнотою з питань нейрохірургії.
I'm very grateful for the opportunity to talk to the whole worldwide neurosurgical society.
Нам приємно, що маємо можливість з України зв'язатися з світом, з України, котра є в стадії війни, але є непереможена.
And it's very important for us to have the option to communicate with the world from the Ukraine. It is in the state of war, but is not still defeated.
На сьогоднішній день, крім загальної нейрохірургії, в тому числі і судинної, в нас появилось дуже багато і нейротравми, пов'язаної з воєнними діями.
Last weeks we have many cases of battle trauma, and it's the new for us. It's well known for our colleagues on East, and we think you will ask them to share their experience in the future about battle, missile wounds, etc. But we here do as well traumatic cases, as well battle wounds, and as well vascular neuro-oncology, vascular neurosurgery, spinal surgery, and more.
За день є декілька ракетних обстрілів, авіанальотів і артилерійських обстрілів. Це тримає людей в постійному стресовому стані. Стрес – це є, напевно, зараз нормальний стан для української нації.
So every Ukrainian now is stressed by repeated attacks by Russian planes, rockets, and even here in the military area of our country we have the few attacks, and this is very stressful for every person, and it's very stressful for all population.
І на цьому фоні, відповідно, загострюються всі хронічні захворювання, які виглядають в такій ситуації абсолютно інакше, ніж вони виглядають в мирному житті.
And here we have the sharp conditions, acute cases that looks much more different than in a normal peaceful life.
Тому я вважаю, що тема конференції є цікава, і, напевно, в короткому часі ми будемо мати нову інформацію про перебіг хронічних захворювань в настільки нетипових військових обставинах.
And that's why the topic of our meeting is really actual and important, and in the close future, I think we will get a new data about the chronic disease and their course in the conditions, circumstances of the military time.
Хочу ще раз подякувати всім, хто нас запросив, хто нас слухає, побажати мирного неба і Україна понад усе. Дякую.
Thank you for everybody who invited us here and have the peaceful sky over your heads, and Ukraine is overall. So thank you to Andriy. He is really the person who organized our service here and the vascular service as well, and we keep in touch every day, discussing cases, discussing our strategies, and discussing our future. So let me go on about the specific topic. It's the neurosurgical treatment of acute ischemic stroke, modern approach. We will focus on the recommendation. We'll discuss some clinical cases on the concern of these recommendations and their application in practice, and we'll discuss some points, some issues about who and when and how should do these surgeries, because as you see in the title, neurosurgical treatment, it's the treatment by surgical procedures. Okay.
Добре, я дякую. Якщо будуть якісь питання, я буду готовий на них відповісти.
If any questions will be, Andrii Tokarskiy will answer them on the end of our session. So, you know about words, the destruction that were produced in the not just the military objects like we hear from Russian channels. It's pity, but we believe in our victory, and we will win. We are sure about it. So we are here in Ukraine. It's the western part of Ukraine where we live in Lviv region. It's about 2.5 million of population. We have 6 centers, stroke units that can provide the primary care for the patient with ischemic stroke. I mean intravenous thrombolytic therapy, and we use the technique trip and ship to get patient to our comprehensive center. Is located here in Lviv. Lviv has about 1 million of population. We have 3 major hospitals, and 2 of them has the neurovascular facilities, and our one on the northern part of city where we are staying now. We will discuss our activity as well. About 7 million people die of stroke every year, and Ukrainians had about 100,020 strokes in 2018. every third one causes death, and it's about 40,000 of deaths per year. So thousands of people live with limited facilities in future. Stroke action plan admitted by Europe Parliament in 2018, as well as our oriented when we are going to with our stroke treatment. We want to treat majority of patients in the comprehensive centers and provide the access to therapy for the majority of patients, decrease the onset to needle time, achieve the IVT rate above 15% and EVT rate above 5%, as well decrease the first month case fatality less than 1 for part of patients for hemorrhagic stroke. What is currently in our we need a good facilities. We have here a really good one, but of course we need to develop. We need to develop the new discipline, neuroradiology, still not admitted in Ukraine, and the radiologists, common radiologists, neurosurgeons, cardiologists, they work together in this domain. We need to provide, and we've provided here in Lviv 24 hours, 7-day working hours for radiology unit. Of course, the question of consumables is always open. We need more and more, and especially now we ask our partners from abroad to help us with consumables, and we get the humanitarian aid. Is very important, and we are very grateful. We have a good material base to CT scanners, new angiographic equipment, etc. I will not stay here. And as well, aeromedical evacuation that works during the last year is very helpful to get the patient early from the remote part of our region. It could be 150 kilometers from the hospital, and patient can get within 1 hour here. In Ukraine in 2021, was done about 500 of thrombectomies. It's about 1.5%. It's too less, and we understand we should do more. With IVT during the last few years, it's the better condition. We have about 5,000 of intravenous thrombolytic procedures done. It's about 5% of all ischemic stroke cases. So, but as well, we need to do more. In Lviv region, we did during last year 48 mechanical thrombectomies and about 250 IVTs. So it's a short statistic about stroke in our region, about 6,000 cases of stroke in our region with mortality rate about 25%. It's our people who work together, the leader of opinion, our radiologists, interventional radiologists, neurologists, neurosurgeon, intensive care doctors, and residents as well. So, and we have in our hospital a neurosurgeon. It's among them, it's myself, but we have dual expertise in both open neurosurgical and mini-invasive procedures. So we think it's the good for treatment of patient, and we have the good perspective in determining the optimal treatment for each individual patient using the most cutting-edge technologies. So patients get to our hospital through the emergency department. It was renewed during last few years, and the new managers in our hospital, they do much to renew our equipment and our services. So next step, it's for 64 slice CT Philips CT. But we do the native CT, we do CT angiography, and it takes about 15 minutes at all. After patient go to interventional radiology department with new, we've got in 2021 Philips Azurion Artis, Philips Azurion 7 new angiographic device. So Department of Vascular Neurology and Neurosurgery, where we treat our patients, where we operate. neurosurgical and neurointerventional procedures, and we do it according to North American and European recommendations that were renewed in 2018, as you know. So during our period of activity since 2008, we did about 1,500 procedures, both endovascular and microsurgical, with point on the ischemic stroke treatment and prevention, thrombectomies, in total more than 100 cases, and the carotid artery stenting we've started to do not a long time ago, but we again do it more and more.
Professor, sorry for interrupting, but can you keep your microphone close to you all the time, because your voice is diminishing sometimes?
Of course, I will try to be more loud, of course. As you know, we have two ischemic thresholds, and the first threshold, when penumbra appears on the brain, it's less than 20 milliliter of blood supplied to 100 gram of brain parenchyma per minute. So if the second threshold is passed and less than 10 milliliter, we get an infarction. So the salvage the penumbra is the major goal of our treatment, of our reperfusion that we can meet by intravenous thrombolytic and intraarterial therapy as mechanical thrombectomy to get the reperfusion. We should do immediately blood pressure check, glucose level check, and ECG to proceed with thrombolytic therapy. And later, if we have CT and CT angiogram, we can plan the patient for endovascular thrombectomy. It's especially indicated if thrombus exceeds 8 millimeter in length, and patients who are eligible for intravenous alteplase should receive it immediately, even if endovascular therapy has been considered, and otherwise the patient under consideration for mechanical thrombectomy should not stay under observation after intravenous alteplase to assess the clinical response. We immediately transfer patient to catheterization laboratory. Patients should meet a few criteria concerning the age, location of occlusion, but we follow 3-6 rule. The IHSS scale should be more, aspect scale should consist 6 and more points, and onset should be within 6 hours. Here you see the scheme of aspect score, native CT. It's very easy to calculate. We have 10 points in normal brain. If we have any hypointense lesion in any vascular territory, so we get -1. So if we have 3 or 4, -3 or 4, so we have 6 points we can operate. If patients who are potential candidates for mechanical thrombectomy, imaging of intracranial, of course, but also of extracranial carotid and vertebral arteries is reasonable to provide useful information on patient eligibility and endovascular procedural planning. It's a new recommendation, but we meet it every day. You can see here on this CT angiogram, right MCA artery with thrombus on the 1 and 2 segment. And as well, you can see here no contrast in carotid artery. It's why, because it was the carotid artery dissection on the neck. And if we do not follow this recommendation, we can follow wrong protocol of CT angiography. And this here you see the cutoff carotid bifurcation, and we have no information about the condition, what can appear from there, the new thrombus, emboly, severe stenotic lesion, etc. So we should extend it for our CT doctors, CT radiologists. In case of decision, as I told about AVT, patient is directly going to cath lab, and the RTPA infusion should not be interrupted. Again, it's extremely important. Other recommendation, you know, but what is important, again, a level of arterial blood pressure. That's why the monitoring and intensive care doctors, they are very important people here, because we should not allow the blood pressure exceed with 180 to 105 millimeter of mercury threshold. It makes the results much more worse. For the patient within 6 hours, no extensive neuroimaging is indicated. But if patient exceeds 6 hours, need to do CT perfusion or MR diffusion images. As in our experience, it's not many patients we've got. We do routine procedures up to 8 hours, and new recommendation, they allow us to do it up to 7.5 hours with routine neuroimaging and AVT. But if we are much more later than 6 hours, of course, we need to do CT perfusion to check the penumbra and target mismatch, and to plan the procedure. And about 9%, according to literature, of patients who are admitted after 6 hours up to 24 hours from the symptoms onset will benefit from endovascular treatment as well. Otherwise, we get a brain infarction and we can do nothing, just the general care and medical rehabilitation. What vascular access do we use? We use transfemoral in most cases. Last year, we started to use transradial approach. It's just 7 cases, but it's suitable for patients who have the contraindication for femoral approach or some other technical issues. Nevertheless, we put a peripheral arterial puncture introducer insertion. Usually we use as first step 6 French introducer. We do selective angiography. We use long guide wire and make the replacement for the long introducer. We use Terumo destination 6 French and 90 centimeter length. Routinely, if the problem with navigation, we use we change to 8 French introducer, and we use 3-axial system with either 8 French catheter and this distal access aspiration catheter. Usually we use Sophia, React, and Penumbra 5-6 French, and microcatheters that we navigate up to. And more distally, we use microcatheters Ribar 18, Phenom 21, Phenom 27, Headway 27, and after we get distally to thrombus, we make the super selective angiography to rate the thrombus left and to check the position of microcatheter distally to the thrombus. To put the stent, we deploy the stent for 5-8 minutes, and we use the aspiration during about 3-4 minutes when stent is already deployed, and after we make thromboextraction with persistent aspiration, so-called Solumbra technique. So we are satisfied about it. In the cases when the navigation is not complicated, in younger person, not very atherosclerotic patient, we try to use the distal access catheter first and use the ADAPT technique. And in some cases, we will discuss it later, we get the reperfusion during the first passage. It's one case when we used the transradial approach because it was the elderly lady with severe neurological dysfunction and Lery syndrome, and the left femoral arteries were totally occluded. So we used transradial approach, and during the first passage was achieved the total reperfusion MTC free. It's other more complicated case with patient with occlusion of ICA, left ICA on the neck. With good collaterals, we always pay attention to collaterals, and we use the Assit and Sear scale. Here it's 2-3 point on Assit and Sear. And the good collaterals gave us the better chances for patient brain to survive the ischemia without major dysfunction in future. And after the opening of ICA, we've noted the severe stenosis on the ICA bifurcation, as you see here. and the stop contrast on the siphon of left ICA inside the cranium. After the thrombectomy was made with stent retriever, we've got the result as about MTC2A. So it was a discussion during procedure. Should we follow and put in the stent again and again to get the thrombus from M2, M3 segments? The benefits are uncertain for M2, M3 segments, but the recommendation renewed that it is reasonable for carefully selected patient. As we noted in our cases, extensive manipulation with stent, especially we should avoid the forwarding the stent without sheath. So it's very important, really. But the more distally we work, the higher the risk of hemorrhagic complications. So here we stop because, as you noted before, the good collaterals were the warranty for the brain parenchyma. So, and again with IC stenting, it was the next discussion: should we put immediately carotid stent? I'm sure many physicians are thinking about it during surgeries, but renewed recommendation is that intravascular therapy of tandem occlusion, both extracranial, intracranial, during the initial thrombectomy may be reasonable. Here we have no word about the carotid artery stenting. So, of course, we work with carotid artery, we make thrombectomy from extracranial carotid artery, but to stent it or to not, this question, of course, is open. And again, how many passages by stent retriever or aspiration catheter should we do? So, the majority of my colleagues were limited to 5 passages. As I found in the manufacturer's brochure and for ERIC thromboextractor, they recommend up to 6 passages and describe the successful reperfusion after 6th passage. So, but more the passages, the worse clinical result, it's true. In our recommendations, it was the European recommendations. No recommendation can be provided regarding which treatment modality should be favored in patients with LVO-related stroke in background of carotid artery stenosis and occlusion. So these patients should be included in dedicated randomized trials, and it's no consensus about should we stent it or not. But you should see here another case when we've stented acutely carotid artery for the patient and with good result as well. So what in this situation, when the indication for intraarterial thrombolytic therapy is other option that we can use a salvageable technique to get a better technical result. In these cases, it's not the high level of recommendation, of course, but we were based on MC3 trial. It was 2015 when the intraarterial thrombolytic therapy was the most major used technique at this period of time before stent retrievers introduction to routine practice, and they recommended we used 15 milligram of Actelisa. They recommend up to 22 milligram to 4 milligram in bolus and infusion of remaining medium 10 milligram per hour. It can be used if we need to get the goal. The goal is MT3 when we can expect the good recovery. We can use different technical decisions. Here you see the chronic occlusion of left ICA on the neck, and we see the acute thrombosis of left MCA. So the excess was through the femoral artery, through the right carotid artery, and through the anterior communicating artery to opposite left MCA. And we've introduced the navigated well the stent there. We used 2 passages, but we get no reperfusion on this case, but this technique can be safely used on patient as well. So another case, quite complicated case with acute occlusion of right ICA in the neck. After opening of ICA, we found the severe stenosis of ICA, intracranial thrombosis. So it was performed the thrombectomy from extra intracranial part of ICA with stent retriever. You see here stent retriever on the right image. After we did balloon angioplasty of this stenotic lesion, we have no stent prepared for the. We have a few stents by governmental support. We can use it immediately, but this case we have not. We used the balloon angioplasty, and after the opening, we noted the occlusion of ICA. We've used the same stent. The carotid artery bifurcation, we opened it. After we noted the post bifurcational M1 occlusion, we did again the stent retriever thrombectomy here with good reperfusion of the patient and quite good condition on the neck ICA. So different techniques we've used in percentages. I will just list aspiration and the stent retriever. We used them together, as I told. Aspiration as the first passage, what was effective in 21% of cases. Primary thrombectomy we did in 43% of cases. In former times, when we have no stents, we used thrombus fragmentation and intraarterial thrombolytic therapy. It was before 2017. And tandem occlusion, it was every fifth patient. Passage amount in the median passage amount was about 3. So what about evidence about contact aspiration? The new recommendation was this, there is no evidence that contact aspiration alone improves functional outcome compared with best medical treatment in patient undergoing MT. There's currently no evidence that contact aspiration alone increased the rate of reperfusion over thrombectomy using the stent retriever. Therefore, we suggest the use of stent retriever over contact aspiration alone for mechanic thrombectomy in patient with acute ischemic stroke. So here it's a low evidence about this recommendation, but as in our practice, if you succeeded to get up to the thrombus with distal access catheter and make thromboaspiration at this moment, that's extremely effective. So I think it's under the course, and this recommendation will be renewed. In our experience, the practical result where the next is on this diagram, 76.5% of cases, we've got MTC-2B and higher reperfusion rate with use of thrombectomy and thromboaspiration, and the intraarterial thrombolysis alone that we used for many years gave us less than the half of reperfused cases. The time is different. We work about to shorten it, and we did it during the last 4 years. In the middle, stroke to door time in our region is about 1 hour, a little bit later. Door to needle, 57 minutes, stroke to needle, and result 19, about 100 minutes, and door to puncture, about 50 minutes. But during this time, patient got the CT, angiography, neurological assessment, glucose level, ECG, and the thrombolytic therapy is already started. So what other conditions we have to treat when we work with neurovascular patients? It's rare, but we can encounter patients with intracranial stenosis. I will be very short for discussion because we have no recommendation about the benefit of these procedures. The expert opinion is if patient has critical stenosis, 90% and more, symptomatic stenosis of the vital vascular territory, of course, we will proceed with stenting. Like in this case, patient got an ischemia of brainstem because of critical stenosis of proximal basilar artery, and we've used the very short coronary stent onyx to repair this lesion. Patient passed through control about a year after procedure, and it was the remnant stenosis about 45%. So it's the favorable treatment, but we of course cannot recommend it in routine practice because we have no recommendation about this method, and all recommendation is against this contra this method. About decompressive craniectomy, the consensus exists that mortality rate and again poor outcome are much more rare in the patient aged 60 years and less, and with space-occupying hemispheric infarction who can be treated surgically within 48 hours from the stroke. It's very important that we should discuss with relatives and representatives of patient about the future of the person, because in majority of cases we have the high disability rate, and the substantial disability will limit the life of all relatives. So we should discuss it, but in cases when we have young person with deteriorating level of consciousness and with proved malignant brain infarction, we usually provide the decompressive craniectomy, as well as we try to do in case of cerebellar infarction. Nevertheless, the benefit and risk of surgical decompression is to reduce the risk of death and poor outcome is uncertain. In these patients, we should know it, and in literature we have a few series of 7 up to 25 patients treated surgically with malignant cerebellar infarction, but the majority of surgeons, they think that patients mostly benefit from posterior fossa decompression of these cases. But again, expert consensus statement is that there is insufficient evidence to support its routine use. Again, it is well known that the compressive surgery, the diameter of craniectomy should be at least 12 centimeters. So if we do less, we do nothing. Patient with space-occupying hemispheric infarction, it is no certain would they benefit from ICP monitoring, and majority group members, expert members suggest against routine ICP monitoring on these patients because of no reduce of the risk of death and poor outcome. Okay, so we should understand, and we want to understand why we get sometimes so different results. Even you have two similar patients, the same age, the same gender, and the same angiographic. But in some cases, we have a good recovery, some cases better one, some cases good recanalization, in other cases we cannot. It is believed that vascular anatomy has a direct impact on the complexity and course of mechanical thrombectomy. And its result in turn determines the degree of brain reperfusion and the clinical effect of treatment. So we've decided to analyze the effect of intracranial artery curvature and thrombus composition on thrombectomy result in acute ischemic stroke caused by large vessel thrombotic occlusion of internal carotid artery and or middle cerebral arteries. It was just 25 patients with that data, whose data was used on this small study. The mean age was 67 years. And we did the measurement of internal carotid middle cerebral artery angle, ICP-M1 angle, and removed blood clots were fixed in formalin and examined by light microscopy with staining by hematoxylin eosin, orange-blue, red-blue technique. So in case one, we noted the wide open ICMC angle angle 136.2, and using the routine instrumentation, as you see here, we've got after the second passage the excellent MTC3 reperfusion. In other clinical case, we've got worse reperfusion with some distal embolization, because as we noted here, the ICMCA angle was mostly direct and consisted 92.7. So the angle ICA M1 was insignificantly but larger in group MCTC2B3, so good reperfusion, when comparing with patient of group MTC02A. The same we noted with patient with a low number of passages during surgery, 1 or 2 passages of stent, have recorded statistically significantly larger angle ICA M1, on average 180, had balls with a number of passages 2 and more, 103 degrees. And the duration of mechanical thrombectomy is very important because, as we know, if the procedure lasts more than 60 minutes, usually we get no results. We've paid attention to 90 minutes in our real. So a patient with larger vascular angle, ICA M1, mean 125 versus 111 in patient with longer interventions. So it was a statistically significant difference. So the more open this ICA M1 angle, the more easy we can operate upon the patient. So about thrombi, we've noted some differences on the their structure. It depends upon the age of fibrin fibers inside the thrombus. They have a different blue or red color on the technique, as we noted, red orange technique of staining. And in the thrombus were stained red. With younger thrombus, it was more favorable. So we noted that small curvature of ICA and it branches, and as a result, a great value of angle ICA M1. And or presence of fresh blood clots are favorable for higher perfusion rate and decrease in number of the passages and duration of the procedure. So we need many good conditions around us to work effectively and safely with those patients with acute stroke. And well known is the requirements to comprehensive stroke center, but we should have a special stroke team with experienced personnel. We should have around the clock access to neurointervention and neurosurgical support. We should have the imaging 24 hours a day, including CT imaging, including CT angiography. We should be able to intravenous therapy with Altiplaza, and we should have the on-site stroke center. It should be as a geographically defined unit for the treatment of stroke patients with documented protocols, with valid science-based guidelines for the treatment of acute stroke and early access to rehabilitation and treatment. In conclusion, thromboextraction, thromboaspiration, thrombectomy, mechanical thrombectomy is an effective, extremely effective therapy of acute ischemic stroke, but only with next conditions, qualified surgeons, neurologists, nurses, intensive care, and good cooperation between different medical services. You should have sufficient equipment, sufficient consumables, and timely admission of patient to hospital is of extreme importance. So thank you for your attention. Thank you again for invitation. I wish peace for everybody, and if you have any questions, we will be happy to answer them.
Many thanks for your wonderful lecture. I'm not familiar with this topic. I just wanted to know which kind of retriever do you prioritize? Which one do you prefer, the retriever, when you have the perfusion?
Sorry, Nana, because I didn't understood the end.
You don't understand the question? Which kind of retriever do you prefer?
Which type of retriever?
Yeah.
We have different types of retriever on the market, and it was a real evolution of retrievers during last 20 years. But since 2015, when the results of SWIFT Prime trial were published, we have the first choice for stent retrievers, and we routinely use, it depends upon the governmental support, of course, but we routinely use solitaire stents of different configuration. They could be detachable, not detachable, solitaire 2, solitaire AR, solitaire platinum, solitaire X. So we have different options, yes.
Sorry, Professor, can you stop your screen sharing?
I'm sorry, does the government pay for this surgeries completely, or what is your insurance, government insurance house? I mean, for example, in Georgia, 70% of these kind of endovascular surgeries are covered by government insurance. And when it is the open surgeries, 100% of them is covered. For some reasons, this is the difference. And how does it work in Ukraine?
Sorry, before that, Professor, can you please turn off your screen sharing?
Screen sharing, okay.
Yes, stop screen sharing, please. Yeah.
Yes. Yeah, I stopped it, yeah. Sorry, so about governmental support, we are always happy that we have any. Of course, it does not work in the 100%. 100%. We have some periods of time when we have no support, and in some cases, patients should pay for some instruments. Not for all, but for absent at this moment. We have total support for acute ischemic stroke. Why? Because we have no time to discuss the instrumentation with relatives. We can do acute mechanical thrombectomy during last year and a half, I think, maybe 2 years, totally free for patient. In case of aneurysm surgeries, embolizations, in some cases we have lack of coils, we have lack of specific size of coils, and patients should pay, but it's rare. Open surgeries, we have arterial clips provided by government. Actually, currently we have about 55 clips in our operating department, so it's not a problem.
And is endovascular surgery kind of part of training for your residents? I mean, is it in the standard training course? For example, for us, it is not.
Yeah, everybody who wants to be trained on endovascular surgery, we welcome these people. We have not established specialty in Ukraine yet. We have no neuroradiology as the specialty. So in our department works neurosurgeons, works radiologists, works cardiologists, works surgeons. So and they do different procedures, but to do the neurovascular procedures, you can be a neurosurgeon, you can be a radiologist after specific training, and you can do these procedures as well.
Okay, now I have to move to the chat section. We have a few questions from the chat. So Dr. Jakub Sercote is the head of West Georgia Medical Center, and he asks 2 questions. The first is that thanks for your wonderful presentation. And do you use dynamic CT after operation? Do you use dynamic CT after operation?
Yes, thank you for the question. You mean dynamic CT after stent deployment, stent implantation, as I understand? No, we don't. We don't use. Yes.
Okay, and the second question from the same person is, do you have any experience to use EMBO trap? EMBO trap. Don't you understand? Do you have an experience to use EMBO trap?
EMBO trap. What is EMBO trap?
Yeah, what's
it looks like it's a device for to remove the embolus.
Maybe we can.
Or it's a device for femoral closure. It's a device for femoral closure, or
I'm not sure about the details. If you, Dr. Steven, stent retriever from Johnson Johnson, you explained.
No, we have no this type of stent. No.
Okay. Okay. So what is the ideal, Dr. Dews asks, what is the ideal, I'm sorry, just a second, ideal aspiration flow rate for TICI grade 2B3 reperfusion in Solumbra or ADAPT technique? Where are we technologically at the point of aspiration catheters?
Where are we technologically at the point of aspiration catheters? Now, in my opinion, we have very substantial progress on the design and of aspiration catheters. Even during a few years, they are much more easy to navigate. They have the bigger bore size, and we routinely use the biggest we have available. So we use Sophia 6 French Plus, it's 0073. We use React 0071, and we are very satisfied with their. We started to use Penumbra as well. It's just a few cases, so I'm not sure about it, but I think it's the good one. And what you mean the ideal aspiration flow rate? Arterial pressure, or what is meant?
Okay. So also there is good wishes, like our hearts are with you, Dr. Oktar says, our hearts are with you, and it is our deepest wish that you may achieve long-last peace. That's just a comment in comment sections.
Yes,
okay, another question from Dr. Jakob Sertzwat is, what about anti-aggregation management after carotid stent during a tandemic lesion?
Yes, if we need to acutely put the stent, we do 300 milligram of acetyl salicylic acid, and we follow patient with double antiplatelet therapy during half of year, 6 months, yes, with clopidogrel and aspirin. After half of year, we usually leave one medication for the year, and it's enough on our experience.
And how often do you use thrombolytic therapy before the surgeries?
What therapy?
Thrombolytic, like alteplase, retiplase.
Yeah.
That's my question. How often do you use these direct thrombolytic therapies before the surgeries?
Always, if it's possible. If patient is eligible for thrombolytic therapy, we use it anyway. It should not depend upon our future actions. So if patient is eligible as well for thrombectomy, he got IVT, intravenous thrombolytic therapy. Bolus should not, and the main dose should not be postponed more than 4 minutes. It's very important. So if you did bolus, it's 10% of dose of thrombolytic. You should be within 4 minutes to go further with main dose, with infusion. So we do infusion on CT, one vein for thrombolytic, other vein for CT angiography, and it works in our hospital indeed. During the last, it was not easy to manage and do it to work, but make it to work, but it works. And the patient goes to other cath lab with already on course of thrombolytic therapy, and we do our procedure and the vascular procedure during thrombolytic therapy. It's true. We leave introducer in the artery, we suture it to the patient's skin, and we withdraw it 24 hours later.
Okay. From the question of Dr. Deuce, there were two subsections, and just wanted to make sure that the first part is properly answered. So the first part of the question was, what is the ideal aspiration flow rate for TICI grade 2B3 reperfusion in Solumbra or ADAPT technique? That was the first part of question, and I'm not sure that we have.
Yeah. I asked it, what is mean aspiration flow rate? You mean suction vacuum rate?
Yeah, he says ideal aspiration flow rate for TICI grade 2B and
we have Medtronic aspirator. We put the aspirator to the catheter at the moment when we are with stent inside the thromb. We ensure with stent our distal access catheter. We go up with distal access catheter to the thrombus, and it takes about a few minutes. The total time we need to stay with stent inside the thromb is about 8 minutes. So 2-3 minutes to ensure and to get up. We switch on the aspiration at this moment. And the distal catheter is staying inside the thromb. We get mostly not blood outflow, but with aspiration force, it makes the thromb be defragmented during aspiration, and we wait at this condition about 5-4 minutes on the maximal range of aspiration power. And after we withdraw the stent, after we withdraw the catheter. Yes, it's take 8 minutes at all. I hope I answered the question.
Yeah, I hope so. I don't see any more questions here. I think we're at the end. Yeah, there are no more questions. I guess everything was clear from your presentation. And once again, many thanks for your participation in these very hard times. And we wish you all the best. And many thanks for your wonderful lecture, and many thanks to Dr. Tokarskiy also for
Sorry.
I really hope to meet you in person in better situation and more peaceful situations. Yeah.
Thank you very much for your support, for your presence, for everybody who joined our presentation. It was the pleasure to have such worldwide audience and many people, and share an experience. I will visit your lectures in future, I am sure. So it's very good platform, very good initiative, and keep going.
Thank you very much. Thank you. Dr. Stoicu, maybe you wanted to say something?
Okay. I would like to thank our professors who agreed to be speakers from the beautiful city of Lviv. They are truly excellent examples of neurosurgeons trying to do their job in the best possible way, even under the most difficult conditions. Thanks again.
Thank you very much.
Okay.
I wish you peace for everybody, everything to Ukraine.
Thank you. There are thank you notes from the audience.
Yeah. There is another.
It's not a question. They send you the thank you notes. Dr. Gilbert Corrier says, thank you for your great presentation and very impressive. And there are thank you notes and comments in the chat section.
Okay.
I see here.
And maybe you can answer this question briefly, Professor Nana.
Which question?
From Engin Blues. Can we learn about your experiences in pediatric stroke cases? Is there a pediatric
our experience in pediatric stroke case is limited to hemorrhagic stroke. We are a hospital where we treat just adults, so we have other hospital where pediatric services work, and we have no geographic suite yet. So we do angiography for the small children patient with stroke, hemorrhagic stroke, but we have no cases of ischemic stroke yet.
Okay. Thank you, Professor, again. And I want to thank everyone to joining us today. Bye-bye.
Thank you very much.
Thank you very much. Thanks.